Welcome everyone to Strive's Learning Lab. We're going to be hearing about findings from the Avahan study in Karnataka State in India. And we're very glad to have two speakers today, two presenters. From Karnataka Health Promotion Trust, we have Mohan, who is the Managing Director, a Senior Technical Advisor and Social Scientist with a long history with the Avahan program and the extremely interesting work with organizing sex workers. We are going to begin with Tara Beattie from the London School of Hygiene and Tropical Medicine and from Strive. And both Mohan and Tara have been involved in Strive since the very beginning. So welcome everybody. I'm going to now hand over to Tara and to Mohan.
Thanks very much for joining us today. As Annie says, it's going to be myself and Mohan who are going to present the work today. The title of the talk is Declines in Violence and Police Arrests Amongst Female Sex Workers in Karnataka State, South India, following the India Avahan HIV prevention program. I'm going to unusually start with our key messages. We're trying something new in academia, so we're going to give you some of the take-home findings up front, but please stay and listen to the rest of the talk. So the main findings that we had from our work was that violence experienced and police arrests amongst female sex workers are associated with increased HIV and STI prevalence, that large-scale comprehensive HIV prevention programming can reduce violence and arrests and HIV and STI infection amongst female sex workers, and that violence and police arrest reductions can be achieved at a relatively small additional cost. So just to give you some background, gender-based violence affects 30 to 60% of women worldwide. And globally, women who sell sex face dual epidemics of HIV and violence. So female sex workers are at a disproportionately high risk of acquiring HIV infection. In 110 countries with available data, the prevalence of HIV infection is almost 12 times higher among sex workers than for the population as a whole, with prevalence at least 50-fold higher in 4 countries. And even in very high HIV prevalence countries, HIV prevalence amongst sex workers is much higher than among the general population. Research from multiple settings has described violence exposure from a variety of perpetrators as commonplace. So violence by clients and by police are important daily concerns. And violations include homicide, physical and sexual violence from law enforcement's clients and intimate partners, unlawful arrest and detention, discrimination in accessing health services, and forced HIV testing. Abuses occur across all policy regimes, although most profoundly where sex work is criminalised through punitive law. And violence can undermine HIV prevention efforts, both directly through sexual transmission of HIV and indirectly through decreased ability to negotiate condom use or pursue other protective behaviours. The Avahan intervention was established in around 2003 in India. It was funded by the Bill Melinda Gates Foundation. It was a 10-year program, and it was established in response to what appeared to be an escalating HIV epidemic in India. It was a large-scale HIV prevention program, and it was taken rapidly to scale in the 6 states in India with the highest HIV prevalence. Interventions were targeted to those most at risk. So in the 4 southern states, which are Karnataka, Andhra Pradesh, Maharashtra and Tamil Nadu, the intervention was targeted amongst female sex workers and men who have sex with men. In the 2 northeastern states of Nagaland and Manipur, it also targeted injecting drug users. The intervention initially comprised a standard package of care, which we often see globally, which involves free condoms, peer education, provision of free STI testing services. But this initial standard package of care was later developed to address the key issues facing the female sex worker population. In Karnataka State, which is a state in South India, sex work is mainly street-based and is mainly rural. The targeted intervention started in January 2004 in 20 of the 27 districts, and worked with 60,000 female sex workers and 20,000 men who have sex with men per annum. Now I'm passing over to Mohan.
Yeah, thank you, Tara. I I just set the context, and thank you very much for that. As you all know, Karnataka Health Promotion Trust, under the assistance of Bill and Melinda Gates Foundation, we started working with the 60,000 sex workers across the state in 16 districts. Just to start with, our focus was more on the reducing the risk. But the reality with the sex workers in Indian context is all the sex workers who face the stigma and discrimination largely, and also they undergo a lot of violence, both external from the police as well as the violence within their partners and local goons. And also the sex workers so stigmatized, they do all their profession in a hidden manner, so they are not accessible to many of the social entitlements in the society. So largely these women are highly stigmatized, and they do their profession in a very hide and seek kind of a situation. So when the society is not accepting this as a profession, they also tune to many of that human right violation, so including harassment and the violence. So we realized soon that when we have started working on the risk reduction, that we also need to work on their vulnerability reduction. Unless we address those issues, I think it is very difficult to reduce the risk part of it. So it is almost for us it's a two side of both the same coin. So we started working on those fronts in a very systematic manner. If you see the situation where the sex workers live in, it is all related to her inner circle, something which is very, very relevant to the caste system here, because we have traditional sex worker as well, and in a society like ours, we also have a different low caste, upper caste, this kind of a different caste system in the society. It is a social thing here. So the lowest caste people, we can see more number of women who are practicing the sex work. So these women, not only socially they are actually in the lowest strata of the society, being a women and lower strata of a society, many of them are not gone to school, they are illiterate. So they are also vulnerable to many of the social norms because of the gender and the caste system in the society. So though these women also tend to migrate for their own economic reason, and also to earn the livelihood. So they see this all the first circle, what you can see, these all issues finally make them much more vulnerable, along with the profession what they are doing it. The second circle, it is very much linked with the economic and social. See here, because of their illiterate, they lack skills. Because of their the landless and poor economic status, they also highly depend on the money lenders, and also they have a poor savings. In fact, the majority of these women are not even having the bank account or even the residential proof, because they don't have a house. Either they will be in the street or in the brothel setting. So this is something which is very much linked to all their financial causes. One of the main reasons for their vulnerability is highly linked with the socio issues at one side, and also the financial causes for other end. So this is something equally important to address, where they can also access all the services provided by the HIV prevention program. So this is the second part of it. So how we started working with this group? When we started the initial stage, when we started working on the risk reduction, yes, women always tend to ask that. See, finally the money is important for them because of their own economic vulnerability, which is also social vulnerability, leads to social vulnerability. It is linked to one another. So in this kind of a situation, what we try to understand is that unless we build their own self-confidence, self-esteem, it's very difficult to address her own vulnerability issues. whether it is police or goons or the intimate partners, how to build her own self-esteem. That is the power within part of it. So we try to build her power approach we call power within, where she started participating in many of the critical thinking process, try to understand why my situation is like that. Being a woman, how I am facing so many other aspects, how I am vulnerable to the violence and other goons, why I am paying money for the police, and so on. Because this process took them almost a year long to understand where they are. So that made them to understand the reality and come together with their fellow colleagues. That is what we call it as a power with. Because we know that the single sex workers, she can't address these issues because it is a very, very structural and very established system which they are living in. So how they can address this unless you all come together and fight these issues, it is very difficult. So there was a time when we started working with the sex workers. Many of them, they never used to open up and tell that I am into this profession. But many women started coming together. They started getting into this and started addressing issues together. So then they formed their own CBO, community-based organization, and started addressing the larger issues like police and other violence. So this is the collective action they moved into. Then they built their own governance system. Now almost 30 organizations are created by the sex workers and running their own program, addressing their own issues, including the violence and the social entitlement, so on. So getting from there, now the entire program is divided into two parts. We started working one side from the police and the building the legal empowerment, working with the judiciary, working with the government. See, these are the women which we need to be supported. Try to understand from the one end we started working with these drivers. Another end we also started trying to build the community, empowering the community, how they can collectively address these issues. So how they can build their own crisis management system within the community itself, within 24/7 kind of a team they have built. If there is any women got arrested, immediately the team will rush and try to help her with all the legal and other. So this is the environment we created within this sex worker CBO. Now they are handling their own issues on their own, not only issues, external violence and other issues, even issues related to their own intimate partner and the family, also addressed by the sex workers. So this is the process we try to do. I think you might have many questions about the process. I can answer you later. Now I hand over to Tara to continue the session.
Okay, thanks, Mohan. So in 2012, I attended a symposium at the AIDS conference in Washington, where Kate Shannon from the University of Vancouver presented results from a systematic review her team had been conducting. And although there was emerging evidence from multiple settings that violence against women in the general population was associated with increased HIV prevalence, there was no evidence from female sex worker settings. So myself and a colleague, Shajay Isaac from Karnataka Health Promotion Trust, sat and talked about this. And we thought that with the data that we have, that KHPT had been collecting, that we could answer some key questions that seemed to be hadn't been asked so far. So these research questions were: is violence exposure and police arrest associated with increased HIV and STI prevalence? Has violence exposure and police arrest reduced following the Avahan HIV prevention program in Karnataka State? And then more recently, we've also asked, what are the additional costs of implementing empowerment and violence prevention activities as part of HIV prevention programming? And I've got some preliminary data to show you for that third research question. So what data sources did we have? So we had the data sources I used for the main analyses was a combination of two. So we had serial integrated behavioural biological assessment surveys with random samples of female sex workers in 4 districts at 3 time points. And these were face-to-face interviews followed by also biological testing for HIV and some common STIs, gonorrhea, chlamydia, syphilis. The team also conducted multiple anonymous polling booth surveys with random samples of female sex workers in 16 districts at 4 time points between 2007 and 2011. And that photograph you can see at the bottom right of this slide is an example of a polling booth survey. It's an anonymized survey technique which allows, we hope, helps reduce reporting bias compared to face-to-face interviews. So you have an interviewer who sits at the end, and women are asked a series of 23 questions around particularly sensitive topic, one of which was on violence. And they have a series of coloured cards which sits in front of them, and they post their cards, one colour for yes and one colour for no, and another colour for don't know, in response to the questions that the interviewer asks, and no one can see their answers. And at the end of the survey, all of the answers from everybody are collected up and put into a polythene bag, a sealed polythene bag. Then we also conducted costing data, which was secondary data analysis from 15 of the polling booth survey districts between 2007 and 2011. The costing analysis used a provider perspective using ingredients top-down approach. The other analyses which we conducted used logistic regression analyses to assess temporal changes in reported violence and associations with HIV and STI prevalence. So here are some of the survey questions that we included to answer the first 2 research questions. So the main question around rape, we asked, in the past 1 year, were you ever beaten or otherwise physically forced to have sexual intercourse with someone even though you didn't want to? If yes, who did this? And this question was asked in both the IBBA surveys, those face-to-face interviews, as well as in the polling booth survey districts. Additionally, in the IBBA surveys, we asked a question around physical violence. So we asked, in the last 6 months, how many times would you say someone has beaten you? And by this we mean hurt or hit, slapped, pushed, kicked, punched, choked or burned. And who did this to you? We also asked a question around harassment. Have you faced any problems and or challenges that prevented you from safely practicing your work or accessing STI services in the last 6 months? We asked a question around police arrest. So have you ever been arrested? And if yes, how long ago were you last arrested? Less than a year ago or more than a year ago? And then we asked a question around alcohol use. So during the past month, have you consumed drinks containing alcohol? And the responses were never, every day, at least once a week, less than once a week, not in the past month. So the study population, for the analysis we conducted, we interviewed, or KHPT interviewed 5,792 sex workers in the IBBA surveys and 15,813 sex workers in the polling booth surveys. Most women were illiterate who participated, and most were street or home-based sex workers, with a minority conducting or soliciting clients by phone or in brothels. In the polling booth surveys, 19.4% reported being raped in the past year, and this was against 8.2% in the IBBA surveys. In the polling booth surveys, we asked, the question was asked about any perpetrator. In the IBBA surveys, we limited the analyses to non-intimate partner perpetrators. This was due to differences in wording between survey rounds. So in the IBBA surveys, we were only analysing results from men who had perpetrated violence, who were not their intimate partner, so who were not their husband or their lover. So this included men like clients, strangers, police, pimps or rowdies. So these are the main findings from our work, and we published this work. You can have a look at the paper. It's open access in the Journal of International AIDS Society. So violence by non-partners was not associated with exposure to the program, but was associated with alcohol use and self-efficacy. So women who reported violence in the past year were more likely, and violence in the past year by non-partners, and we define that being by either being raped and or beaten in the past year. Women who reported violence in the past year were significantly more likely to report using alcohol in the past week. They were significantly less likely to report self-efficacy with clients around condom use. They were significantly more likely to report ever having had anal sex with a client, and to report reduced condom use with their last sex with their repeat clients, but not with their occasional clients or their regular partner. Then this was our major finding, was that violence by non-partners in the past year was associated with increased HIV infection, with increased syphilis infection, with increased gonorrhea infection, and with increased symptomatic STI in the past 12 months. Okay, so then we were then interested if there were changes over time following the Avahan intervention program. We first used IBA data, and we found there were significant reductions over time between women in women who reported being raped in the past year. That was significant between round 1 and round 2, and then increased slightly again in round 3. There were significant reductions in the proportion reporting being beaten in the past 6 months between round 2 and round 3. We didn't ask that question in round 1. Being harassed in the past 6 months, again between round 2 and round 3, and between police arrests in the past year between round 2 and round 3. There was also substantial reductions in alcohol use in the past week between round 1, round 2, and round 3. And this was interesting for us because there wasn't a particular alcohol reduction intervention as part of the Avahan intervention. We also then looked at the polling booth survey districts. This is quite a cluttered slide, but the main take-home finding is that we found significant reductions in reported violence, that was that rape question, over time in 14 out of the 16 districts which were surveyed. And the 2 districts where we didn't see reported reductions had sort of very or pretty low violence reported in round 1. That was Balgakot and Bijapur. But in 14 other districts, we found significant reductions in reported violence, so that if we pulled all districts together, that fell from 30% in 2007 down to 10% in 2011 of women reporting being raped in the past year. This research was also published last year by Shajir Isaac and colleagues. The team found also that during that same time period, using the IBBA survey data, that there were substantial reductions in HIV and syphilis prevalence over time, and there were substantial increases in condom use at last sex, and there were substantial increases in program exposure, various components of the program exposure over time between 2004 and 2011. So this is the costing data. I'm presenting data that was compiled by Sudha Chandrika and colleagues. This data hasn't been finalised, so it will probably change when we finally publish it. But it was so it's pretty hot off the press. But it was just to give you some kind of idea of how much the violence interventions cost in these districts. We conducted costing data or costing analyses in 15 of the 16 polling booth survey districts. Of all of the empowerment activities that Mohan described, and the total cost was $2,163,650, with an average cost of around $144,000 per district. The unit cost for reaching the estimated female sex worker population with these interventions showed a decreasing trend over the years and was $11 across the districts. And by comparison, the mean total unit cost per person reached at least once a year under the Avahan program, and this data is from 4 states, not just from Karnataka, was $235. And that program was reaching over 300,000 target population members at least once per year. So the violence reduction intervention costs by input, you'll see that the majority of the costs were, 59% of the costs were personnel costs, with the main other bulk of the costs being the community mobilisation costs and general supplies costs. So the study strengths and limitations are the strengths of our study was that we had biological data and we had data from multiple survey rounds. Our data had multiple study limitations. The analysis we conducted was secondary analysis of existing data. So we might have, if we had started this survey from scratch, we might have asked more detailed questions on violence, for example, and on police arrest. There was no true baseline data because the baseline data was conducted as and when, about 6 to 9 months after the intervention began. We had no control unexposed group, so the intervention happened in all of the surveyed districts. We didn't have any districts where that didn't happen, where we conducted surveys. And cross-sectional data limits the ability to make causal inference. So we don't know, for example, whether violence exposure caused an increase in HIV prevalence, syphilis or gonorrhea prevalence, or whether women who were infected with HIV were more susceptible to violence exposure for a variety of reasons. But with those limitations notwithstanding, this is a summary really of the data that I presented. So female sex workers' exposure to violence are multiple and pervasive, with important impacts on the physical and emotional health of women who sell sex. The incorporation of female sex work empowerment and violence prevention elements into HIV prevention programming is both feasible and effective. And such efforts are relatively inexpensive and can have substantial impact in terms of supporting prevention efforts and reducing harm. Okay, so there are multiple people who contributed to this research that we would like to acknowledge. Primarily the female sex workers in Karnataka, who very willingly, generally participated in all these different surveys and answered our questions. To the Karnataka Health Promotion Trust and the NGO program staff who work tirelessly and very, very long hours over multiple districts over a very long time period across Karnataka. To the University of Manitoba, who we've been collaborating with and who helped set up Karnataka Health Promotion Trust in collaboration with the government of Karnataka. To the India Avahan initiative, which was funded by the Bill Melinda Gates Foundation, and the UK Department of International Development, who supported these analyses. Okay, thank you for participating, and over to everyone to see if they've got any questions to myself or Mohan.
Thank you so much, Tara, and thank you so much, Mohan. That was really fascinating. I think it's extremely valuable to have such an extensive study to be able to draw so much learning from. I liked your research questions that basically answer, is it worth doing this? What do we know about the causes? Does it work? Is it effective? And how much does it cost? From my point of view in research uptake, those are essential questions to be able to put to policymakers, funders, and so on. While we're waiting for people to gear up to ask their questions, I had a couple of questions. I wondered, watching this and listening, it's so difficult to do and to evaluate processes of empowerment and organizing. So I wondered to what extent these findings might be generalizable. Obviously, it's very specific with the caste system, traditional sex work, the particular norms, and that's one lesson that one needs to understand one's context in great specificity. But issues like violence, stigma, and migration are common structural factors. So would you imagine that how generalizable might these findings be for other contexts?
I might hand over to Mohan for this because he might be able to talk a bit more. I think that the findings have been of great interest, and I know that University of Manitoba are leading on trying to introduce some of this, some of the intervention side anyway, into different countries in sub-Saharan Africa. Mohan, do you want to say some more on this?
Yes, there is always a question. Even earlier when World Bank assigned a study on sex workers issues, more on the empowerment, violence, and community mobilization. I think I was part of that World Bank study, which is done across the world, in especially underdeveloped countries. When it comes to situations like violence, it is quite similar everywhere, especially in Latin America, Africa, and Southeast Asian countries. So the pattern of the violence and the other gender norms, these issues are quite maybe different from place to place, but the violence issues, the way the sex work work and the stigma attached to sex work, it is quite common, one or the other way. So in that context, I can generalize the context and the situation of the sex workers. The second aspect because we have seen that the migration. I have seen in sitting in Benin how the sex workers from Nigeria and other African countries migrated to different countries to practice sex workers. I see the same situation here as well. So I don't see much difference in this population. But when it comes to the other social norms and the issues, might be very difficult to generalize to the Indian context. It may be quite different from here and there. But the violence against the women is quite common. That's what my learning and my understanding.
That's great. Thank you so much, Mohan. I think that makes it's always interesting to know how widely we can take some of these lessons and learnings, as well as the differences. I think Martine Colombienne has a question. Martine, will you unmute yourself and ask your question?
I have a comment and a question. Perhaps I'll start with a comment where I saw that on your slide where you look at STIs, you looked at the symptomatic STIs. And I think you probably there had questions about discharge. And we know from previous studies that has little clinical significance. It often doesn't mean you've got an STI. However, what it is a sign of is of distress. So I would see that as a mental health factor. And there have been studies, cohort studies even, I think in Goa by Vikram Patel, to show that effect of that when women have a discharge, they give meaning to that discharge when they don't feel well, when they feel depressed, when they feel weak, and so on. So that's my just my comment, and perhaps that you can do some further analysis on that. Then my question is sort of going back to Annie's question, and I think the stigmatization is everywhere. That's kind of a generalized thing, and I'm wondering how much you see that your intervention was in fact structural, in that when you show the slides with what is in the intervention, community seems to refer to the sex worker community, and I think you obviously need a much bigger budget to sort of change social norms in the larger community. But as my experience is mainly from other parts in India, it kind of seems to be shown that you can empower the sex workers themselves, but it's very difficult to change the community in which they live, and so stigmatization is always there, and is probably also a cause of the violence. And so I'm wondering, with the elements that are more structural, like the sensitization of police, what you might want to add to that if you've got lots of money, but just to sort of see how much this is actually an individual targeted intervention and how much was structural?
So in response to the STIs, yes, no, we, in the paper we talk quite a lot about what does that symptomatic STI in the past 12 months actually mean, and we thought it was probably a sign of mental ill health. Following on from other studies in India which have shown that vaginal discharge is associated with depression among women. Mm-hmm. But we didn't have any measures to be able to take that any further, so it was just a supposition. Could that be what this is referring to? But that it wasn't just around vaginal discharge or abnormal vaginal discharge. It also included sores and warts as part of the symptomatic STI. Yeah, so that's why we presented it. We knew it wasn't a good measure of STIs, but we felt it was a good measure of something bad, and whether that was a combination of STIs and mental health. Potentially, we couldn't unpick it any further with that data. And then over to the intervention, about how much of it was structural. Mohan can talk more about this. There was a sensitisation of the police, but there was also a big drive as part of the structural intervention to work with journalists across the state. So the team did training with journalists from, I think, every newspaper in at both the state level and at the district level in Kannada and English, and they had sex workers as part of that training team to try and sensitise journalists to the lives of sex workers and change the reporting in newspapers around what sex work is, to try and help with some of that to try and help address some of the stigma. Over to you, Mohan.
I think it's a pretty good question. I think it is not started. It's a changing the society perspective of the society is a quite challenging one. When we started doing this, yes, we did face a lot of opposition from all parts of the society, right from the officials, governments, and also politicians, as well as media. I think one of the major interventions we did working with the media, almost 5 years of our initial stay, we trained around 1,500 journalists across the state. And we caught hold of the very, very positive-minded journalists who had sympathizers to social cause and trained them from the sex workers. It is not that we trained, we had trained few sex workers who narrated their own stories and their own issues with the journalists, and we picked up a team of journalists, and those journalists helped us to organize training journalists across the state. So we have seen a big decline in writing against sex workers and putting their photographs in the newspaper, taking their photos and putting in the TV shows. So that's an immediate result. And the other side, the police. Again, we trained around 15,000 police personnel. Yes, you are rightly so that it is very difficult to change their attitude. We had entry and exit kind of a behavior, try to get the glimpse of that, what they enter when they enter the training session, what is their attitude towards sex workers, when they go out, what. So this gave us some kind of a positive note in the initial stage. Now we have reached the stage where the curriculum in each of the police training academy, there is one part on the sex workers. So where the sex workers themselves take this session. The third part is the government, who is the policy maker. The good thing I want to narrate, last 1 month back, Government of Karnataka established a committee, high power committee at the state level with the cabinet rank minister, who is actually touring. Now today she is there with the team of sex workers in one of the districts. Actually he hearing a lot of issues from the sex workers, and government decided to come out with a very, very favorable policy towards sex workers issues. So at least 10 departments came forward and formulated different policies for the sex workers, like housing scheme and also some other entitlements. So this took a lot of time to do that, But the confidence of what I see, that working both from the drivers from the one end and also building the self-esteem of the sex workers from other end, actually both the things need to work simultaneously. I think that can easily change. So now I can tell you that because of this whole questions raised last few years in the Karnataka State, that led to a big debate in the TV show for almost 2-3 months. So that also educated the entire general population in the state. So I see there is very favorable kind of an environment which is built across the different stakeholders. So it is very hard, but it is possible.
Thank you very much, Mohan. That's really clear and very encouraging. Just as a little follow-up, is there a possibility of evaluating the media component more? Because that would be really interesting, because you worked with them for 5 years and how their attitudes sort of at the end of that whole period have changed, and perhaps how they are now a couple of years later. But I'm sure that's sort of a difficult question, but that seems like, that's how you potentially have a big impact, and very encouraging about the police force.
I think we can share, maybe we have some kind of a closely monitored at least 5 national and the state level newspapers and also the media channels for almost 3 to 4 years, and we are seeing the decline, the trend with the media about negative writing of the sex workers and the transgender. Mm-hmm. So that is only because of we are closely interacted with the journalists and others.
I want to agree with Martine. I think that's extremely interesting, looking at the media strategy in terms of shifting norms in the wider society, or at least within the media, but also the efforts and the strategies to build the voice of the sex workers themselves as part of organizing and empowerment. So that would also be really interesting to be able to read more about. We have some contributions, for example, from Shanti Elevazagan, who has worked a lot with the sex workers and been part of this intervention, and who wants to acknowledge the important work that KHPT has done with sex workers and to reduce the violence.
It looked like there was a question from April Murphy.
So yeah, that's so encouraging to know that there's a voice now in the police training, and that it's a part of the curriculum, because I think that's just fantastic that it starts right at the beginning when the new recruits are coming through, especially. And I just wondered, it kind of ties in with the other part of my question with the costing analyses. Was there any costing done on the impact of the impact on the health system? So, use of medication, further referrals, further counselling required, further testing materials, and if those, if there was sort of cost savings in the health system, if the government had those analyses, do you think that they would pour more into training efforts, say, in the police system and in the community?
Okay, so I'm going to answer the costing question because I was hoping Sudha, who did the costing, would be joining us, but I don't see from the participant list that she has.
Mm-hmm.
To say very honestly, I'm not sure. I don't think there has been a cost. I don't think they've done that analysis. Looking at the impact on the health system, I think it's just been looking at how much at the moment, just doing a costing on how much did it cost basically, and interviewing, looking at the costing lines from the NGO and the state level partners, and then interviewing people like Mohan and other people to find out how much time they contributed. So it's not been the most ideal costing because it's been retrospective rather than prospective.
Right.
And I don't think it's included cost savings. I don't think they've looked at that.
Thanks very much, April. I was interested, Tara, you said that if you were starting again, you might ask different questions about violence or more detailed questions. And I wondered, if you can point people on the call, including myself, to any ideas about what is most effective, or some of the most effective questions or lines of inquiry for understanding, well, Tara and Mohan, of course, about understanding violence, because it is quite tricky. Are there sources you would recommend? Are there any comments you want to make? You did read out some of the questions, and maybe you could go back to that slide. But I think that's very interesting for people who are following this webinar.
So now, thanks. That's a great question, actually. And so these questions were inserted at the beginning, so they were asked in the first two surveys in some of the districts in round 3 as well. Since then, we have changed the way that we ask questions to sex workers about violence experience, and it's a 13-item WHO questionnaire that we've adapted. That questionnaire was developed to look at domestic violence amongst women in the general population, but we've adapted it to ask about violence amongst sex workers, both by their intimate partner and by other perpetrators as well. And it asks very specific questions. It starts off around emotion. I think there's 3 items on emotional violence, and then it moves on to different types of physical violence, and then on to sexual violence. There's 3 items on sexual violence as well. Because what we found, not just us but other people have found, is if you ask women, especially before a violence intervention has taken place, is anybody ever violent towards you? They'll say no. But if you ask people very specific questions, like has somebody hit you, have they slapped you, then have they punched you, then they'll say yes. So sometimes it was around definitions or around language around violence. So those are the questions that we've been using in our more recent surveys, this 13-item WHO questionnaire.
That's really interesting. I wonder if after the call, we could add that to the resources on the post about this webinar, so that people can find that, and also any other documents that would help people who are undertaking this kind of research. Obviously, those are the survey questions. I wondered, Mohan, if there's anything from the social science side, or Martine, even if you're on this still on the call, that those might be any sort of insights from investigating from a social science point of view, from a qualitative point of view, some of these questions around violence, around stigma.
Martine here. I think we're currently doing some qualitative research, because it's also about understanding these are standardized questions to be used all over the world, and I still think we kind of need to really look at what the meanings are of those particular questions, and perhaps more for the intimate partner violence than for the client-based and police-based violence, of how women respond to these detailed questions and what they see as violence from a particular partner or not, because they tend to accept, because the social norms of domestic violence are so enormous, one of acceptance of violence, that it's kind of, I'm not sure whether they report this accurately or not, or whether they tend to underreport violence. So I think it's something that will be continued for a while.
Mohan, I don't know if you wanted to add anything in terms of the sort of social science aspect.
No, these are the good points. I think there are few more issues. What we are very much struggling with to understand is the intimate partner violence.
Okay.
I think that is something which is still in the exploration stage. There the context and the things change from place to place, and especially the sex workers, even the pattern also it changes with the home-based, street-based and the brothel-based sex workers. So there is some thing which we can really try to understand with the different groups how this intimate partner violence takes place. I think we are quite clear about the violence from the external forces like goons and the police.
Right.
And I think that's the large number of violences also takes place within the intimate partner. So I think that is the one area where we should do some qualitative stuff as well.
Oh, that's great.
And just to add into that, I mean, one thing that KHPT has found is asking women in the polling booth survey, using the polling booth survey technique, elicits much higher responses than asking people face to face. So that polling booth survey technique has been very good. It's in this context, certainly it's not been possible to ask women to fill in the questionnaire on their own because most of them are illiterate. So that polling booth survey kind of helps find a middle ground between self-completion and completing a questionnaire in front of with an interviewer.
That's great. That's very thorough answers. Thank you, everyone. So I wanted to ask Mohan and Tara, if, as a closing, if anything around your analyses, the research, surprised you. Were there any findings or any evidence, anything you learned that you were not expecting to learn? This might be too big of a question to spring on you in the last few minutes, but if you had anything to add on that question or anything else, please go ahead.
I can answer something very briefly. Is the thing that surprised me was when I very first did that crosstabs, looking at HIV and violence exposure. And I just sat there looking at the results, completely astonished. I didn't think we would necessarily find this in the sex worker population, such strong associations between recent violence exposure and HIV and STI prevalence. I knew that they'd found it in the general population, but I think because sex workers are at such high risk of HIV anyway, and because no one else had reported on this. Yeah, I remember looking at my laptop, completely astonished, going, "Wow, okay, this is really important."
That's really, really interesting and a strong note to leave with. Mohan, anything you'd like to add before we thank everyone and close the call?
No, Annie, nothing in particular, but thank everybody, I think, for taking this initiative. Thank you very much.
That's great. Thank you so much to Mohan and to Tara.